This module explores the relevant airway anatomy. This is to ensure the function and complications of artificial airways are fully understood. The upper border of the trachea is the cricoid cartilage. It is the only complete ring of cartilage in the trachea. The lower border is at the carina, the point of division between the right and left main bronchi. The vertical position of the carina changes with the phases of respiration, usually around the level of the fourth thoracic vertebra, T4. The trachea is typically 10 cm to 13 cm in males, and slightly shorter in females. The trachea is comprised of 18 to 22 incomplete D-shaped rings of hyaline cartilage, each 4 mm in height. These rings are stacked vertically and connected by smooth muscle. The incomplete rings of cartilage are connected posteriorly by the trachealis muscle. This muscle runs longitudinally between the trachea and the esophagus. The trachea can be divided into the cervical and thoracic trachea, according to its arterial blood supply. The cervical trachea is mainly supplied by branches of the inferior thyroid artery. The thoracic trachea and carina. A pediatric trachea is shorter, narrower, and less rigid than that of an adult patient's trachea. Additionally, a pediatric larynx is funnel-shaped with a narrowing at the cricoid cartilage. It also lies more anteriorly and superiorly within the neck, compared with adults. Unlike the horizontal vocal cords in adults, a child's vocal cords are upward slanting. The wall of the trachea comprises of 4 important layers: the mucosa, the submucosa, the cartilage or connecting smooth muscle, and the adventitia. This injury to the trachea may compromise its structural integrity. This can lead to tracheal pathology. If injury to the trachea results in erosion of the tracheal layers, fistulas can form with nearby structures. An endotracheal (ET) tube provides a secure airway through which a patient's lungs can be ventilated. Passes through the mouth and oropharynx, through the larynx, and into the trachea. High volume, low pressure, HVLP, cylindrically shaped PVC cuffs are commonly used for endotracheal tubes, ETT, and tracheostomy tubes. This allows the cuff to conform to the shape and contours of the trachea as it inflates. However, the resulting folds of excess cuff material permit the formation of microchannels. These folds can exert high pressure P. The shape of the TAPERGUARD cuff allows a better match between the diameter of the trachea and the cuff, creating a patented sealing band. This design only has small creases in cuff material and confines them to TH. The TAPERGUARD cuff is dramatically different than the HVLP cuffs. First, the cuff material has lower compliance. Once fully inflated to achieve a seal, overinflation will not result in increased tracheal wall pressure. Compared with a cylindrical cuff, intubating with an endotracheal tube with tapered cuff had fewer adverse effects. Specifically, the incidence and severity of postoperative sore throat and hoarseness were found to be reduced. For the operating room, clinicians can choose the Schilly endotracheal tube with TAPERGUARD cuff. This is available either with or without a preloaded stylet. For the intensive care unit, TAPERGUARD cuff technology is combined with a subglottic secretion drainage system. This may reduce the incidence of ventilator-associated pneumonia, VP. The Schilly EVAC oral endotracheal tube with TAPERGUARD cuff is preferred by clinicians in the intensive care unit. Schilly neonatal and pediatric tracheostomy tubes are designed for the distinct anatomy of neonatal and pediatric airways. Thanks.